Bismillahirrahmanirrahim. Ladies and gentlemen, I welcome you to the third lecture related to the tuberculosis lecture series. In the previous sessions, as you can see in the slide, the things which we discussed in lecture 1 and then the different things related to tuberculosis which we discussed in lecture 2. These are the things which we'll be discussing today, which includes treatment of TB, first-line drugs, second-line drugs, methods of grouping anti-TB agents, reactions to anti-TB drugs, directly observed treatment, short course, and different treatment modalities, including MDR-TB, and which is multi-drug resistant TB, and extensively drug-resistant TB. Then pre-treatment evaluation, follow-up schedule during drug-resistant tuberculosis, then management of patients who interrupt treatment, childhood tuberculosis, tuberculosis in pregnancy, and tuberculosis associated with HIV infection, diabetes, and tobacco. And at the end, we'll discuss the NTB strategy. The development of effective treatment for tuberculosis has been one of the most significant advances during this century. With the evolution of controlled trials, the chemotherapy of tuberculosis is now more rationally based than in the treatment of other infectious diseases. Chemotherapy is indicated in every case of active tuberculosis. The objective of treatment is cure, that is, the elimination of both the fast and slowly multiplying bacilli, including the persisters, from the patient's body. The effects of chemotherapy are judged not by the anatomic healing of the lesions, but mainly by the elimination of bacilli from the patient's sputum. Chemotherapy should be easily available, free of charge to every patient detected. It should be adequate, appropriate, and apply to the entire pool of infections in the community. I would say that patient compliance is critically important, and the patient must take the correct drugs at the correct dosage for the correct length of time. Incomplete treatment puts the patient at risk of relapse and incomplete treatment, I would say, puts the patient at risk of relapse and the development of bacterial resistance. And as I highlighted in the content section, we will be discussing drug resistant tuberculosis, multiple drug resistant tuberculosis, and extensively drug resistant tuberculosis. And in addition to the development of bacterial resistance, importantly, the community at risk of infection with resistant organisms has to be tackled. As far as the anti-tuberculous drugs are concerned, we have different types of drugs available. The first is rifampicin, which is a powerful bactericidal drug. It is a better sterilizing agent than isoniazid, which we call, is abbreviated INH, and it permeates all these all tissue membranes, including the blood-brain barrier and the placental barriers. It is equally effective against intracellular as well as extracellular bacilli, and it is the only bactericidal drug active against the persisters or dormant bacilli, which are found in the solid caseous lesions, all other drugs being inactive in those cases. In this regard, it is a distinct advantage over INH. Rifampicin is one of the special is of special value when the bacilli resists other drugs, and in combination with INH, it can cure even extensive tuberculosis in about 9 months. In this slide, you can see the alternative methods of grouping anti-TB drugs. Since the slide is in front of you, you can go through it easily, but I will be first highlighting the drugs. Then the second is, this is another slide showing the same kind of grouping. The second first line drug is isoniazid, INH, commonly known as INH, which ranks among the most powerful drugs in the treatment of tuberculosis, and it can easily penetrate the cell membrane and is thus active against intracellular and extracellular bacilli. As far as its actions are concerned, its action is most marked on rapidly multiplying bacilli. It is less active against slow multipliers, and INH gets widely distributed in the body, including CSF. Its ease of administration, freedom from toxicity, and low cost makes it an ideal component for any drug regimen. The third drug is streptomycin, and of course, all these drugs have some side effects. They also have some toxic effects. Also, I'll highlight those in a slide later in this session. Then we have streptomycin. Streptomycin is a bactericidal. Is bactericidal, and it acts entirely on rapidly multiplying bacilli. And it has been shown that when bacilli are multiplying rapidly, they come out of the phagocytes and are mostly extracellular and are therefore susceptible to streptomycin. And the daily dose of streptomycin is around 7.5 grams in a single injection. I'll also be showing you later on in different slides the dosages, how do we calculate the dosage of these medications according to weight, and so on and so forth. Then we have another first line drug, which is also a bactericidal drug, and this is pyrazinamide, and it is particularly active against the slow multiplying intracellular bacilli, which are unaffected by other drugs. And it has been found to increase the sterilizing ability of rifampicin. Therefore, pyrazinamide has been incorporated in short course chemotherapy regimens. And then the last it is a bacteriostatic drug. In the first line drugs, this is ethambutol. Ethambutol is bacteriostatic and is used in combination to prevent the emergence of resistance to other drugs. And it is given orally. Its major side effects are retrobulbar neuritis. This, however, does not occur at the usual dose. And ethambutol has replaced para-aminosalicylic acid, commonly known as PAS, almost entirely among adults. As far as the second line drugs are concerned, these include fluoroquinones, then we have ethionamide, then we have capreomycin, we have kanamycin and amikacin, we have cycloserine, thioacetazone, macrolides, and bedaquiline. So I'll be discussing these when we are discussing the treatments. These are a few reactions to anti-TB drugs. As I mentioned, that I'll be highlighting these things as well. And as far as thioacetazone is concerned, the reaction could be severe rash, agranulocytosis. Streptomycin can cause hearing loss or disturbed balance. It affects the vestibular system. Then ethambutol, as I already mentioned, causes visual disturbance, poor vision, and color perception is affected. Then rifampicin can have can cause renal failure, shock, or thrombocytopenia, and pyrazinamide can cause hepatitis. So this, of course, the benefits outweigh the disadvantages of these drugs, because of course we have to treat the patients. A little bit about the directly observed treatment short course, which is commonly known as DOTS, and it's a directly observed treatment short course chemotherapy. DOTS is a strategy to ensure cure by providing the most effective medicine and confirming that it is taken. That's most important because we find among patients that at times they skip medications, they do not take medications regularly, and that later on causes resistant tuberculosis. So it is the only strategy which has been documented to be effective worldwide on a program basis and endorsed during the intensive phase of treatment. A health worker or other trained person watches as the patient swallows the drug in his or her presence. That's the most important thing. And during continuation phase, the patient is issued medicine for 1 week in a multi blister combi pack, of which the first dose is swallowed by the patient in the presence of the health worker or trained person. The consumption of the medicine in continuation phase is also checked by a return of empty multi blister combi pack when the patient comes to collect medicine for the next week. And the drugs are provided in patient wise boxes with sufficient shelf life. In the program, alternate day treatment is used, and the cases are divided into two types of categories: category 1 and category 2. And I will be showing you the different categories as well. As far as the recommended drug regimen is concerned, first of all, we have this daily dose regimen, and you can see in these tables, these are self-explanatory, so I won't be discussing everything in detail. You can go through them, and we talk about the type of TB case, either it's new or previously treated, and then what is the treatment regimen in the initial phase, and then in the continuation phase treatment regimen. And as far as these medications are concerned, these abbreviations are of the medications. Then the type of TB case, if the treatment regimen is in the initial phase, and the medicines which are being given are for rifampicin resistant plus isoniazid sensitive or unknown, or if there is multiple drug resistant tuberculosis. So you can see the duration of treatment is for 6 to 9 months, and in the initial phase, and then up to 18 months in the continuation phase. These two tables show treatment of multiple drug resistant TB and extensively drug resistant TB. And these patients are to be treated with the standard treatment regimen for multiple drug resistant TB that contains 6 to 9 months of initial phase or intensive phase, I would say, with kanamycin, levofloxacin, ethambutol, pyrazinamide, ethionamide, and cycloserine, and 18 months of continuous phase with levofloxacin, ethambutol, ethionamide, and cycloserine, and all drugs are given daily under supervision. All multiple drug resistance, MDR stands for multiple drug resistant TB isolates would be subjected to testing as well. And then we have this extensively, XDR stands for extensively drug resistant TB. And in these cases, XDR cases will be treated with the standardized treatment regimen comprising of injection and the rest of the medications. And the duration of the phases will be, initial would be for 6 to 12 months, and then the continuation phase would be up to 18 months. As far as the mono or poly drug resistant TB cases are concerned, on receiving the reports showing mono or poly drug resistant tuberculosis from the quality showed laboratory. Patients and their family members are initially counseled, and patient is referred for evaluation and initiation of the regimen for mono and poly drug resistant TB to the drug resistant TB center, and repeat rifampicin for drug resistant therapy to be done in case a result of mono or poly drug resistant TB is available after 6 to 8 weeks. As far as the mono drug resistant TB is concerned, the treatment regimen consists of injectables and as well as other tablets. Then the total duration of treatment will be 9 to 12 months. The intensive phase, the intensive phase is for 3 months with scope for extension to a maximum of 6 months, and the continuation phase is for a fixed duration of 6 months. Treatment with bedaquiline containing regimen. As far as this is concerned, all eligible patients are subjected to thorough pre-treatment evaluation at the drug-resistant TB center, and the drug-resistant TB centers must ensure that necessary laboratory facility and consultancy services from various specialties are available at site, because patients may have other systemic illnesses. Once the results of the second line drug sensitivity tests are available, patients to be treated with bedaquiline, which is also abbreviated as BDQ, containing regimen are identified, and the TB drug resistant TB center committee decides the appropriate regimen, and all patients are counseled and managed indoors for a mandatory period of 2 weeks to complete initial dose of the drug. And after discharge, the treatment is continued on ambulatory basis with strict adherence of treatment and follow-up schedule. As far as who are eligible for this drug, it would include multiple drug resistant or rifampicin resistant tuberculosis, or similarly extensively drug resistant tuberculosis, treatment failures of multiple drug resistant tuberculosis, treatment failures of extensive drug resistant tuberculosis. I've already highlighted these things. This chart gives you an overview of regarding choosing the multiple drug-resistant TB treatment regimen in patients with confirmed rifampicin resistant or multiple drug-resistant TB. So the criteria you can see in this slide, that do any of the following apply? You have to see that, and confirmed resistance or suspected ineffectiveness to a medicine in the shorter multiple drug resistant TB regimen, except isoniazid resistance, or is there any exposure to more than or equal to one second line medicine in the shorter multiple drug resistant TB regimen for more than 1 month, or intolerance to one or more than one medicines in the shorter multiple drug resistant regimen to a risk of toxicity, example drug interactions, then pregnancy, extrapulmonary disease, at least one medicine in the shorter MDR TB regimen not available in the program. So when you see if the answer to these questions is no, then shorter multiple drug resistant TB regimen is used. Then you can see the intensive phase, the duration is around 4 to 6 months with 4 second line drugs, and the continuation phase is for 5 months with 2 second line drugs. But if the answer to these questions is yes, then individualized conventional MDR or rifampicin resistant tuberculosis regimens are used, and in the intensive phase, the treatment is up to 8 months, and composition is 4 or more second line drugs. And in the continuation phase, The duration is 12 months or more, and the composition is three or more second line drugs. You can just go through this chart. You can see in these tables, these are regimen and dose administration tables. Uh, so these are again self-explanatory. First is the fixed dose combination for adult TB patients. The daily dose regimen is mentioned, and the number of tablets to be given according or injection strength is according to the weight of the patient. Then the fixed dose combination for pediatric tuberculosis, and this also includes the number of tablets required according to the age of the child. If it is 4 to 7, sorry, according to the weight of the child, and if the weight is 4 to 7 kgs, then you can see the tablets required, and they progressively the number of tablets go on increasing as the weight of the child or teenager increases. More precisely, child. Then dose for multiple drug resistant TB in pediatric patients less than 30 kilogram body weight. So you can see the dosage of all the medications: kanamycin, levofloxacillin, ethianamide, cycloserine, ethambutol, pyrazinamide, sodium para-aminosalicylate. Then drug dosage for XTR TB pediatric patients, you can see in this. And this is according as per comparison handbook to the WHO guidelines for the programmatic management of drug resistant TB. Then you can see drug resistant TB dosage and weight band recommendations. Again, these are given in detail. So it all depends that the patient you are treating, what is the weight of that patient. Normally, there is a benchmark used that if either the patient is below 50 kilogram of weight or above 50 kilogram of weight. So if you can see over here, there is one column in which the weight is from 46 to 70 kgs. So rather than 50, they've used a more safe figure of 46 kilograms and above. So the dosage changes, like if the patient is 16 to 25 kg, the rifampicin, one tablet of rifampicin is given, which is 300 mg. And if it is 46 or above, so then two tablets are given, 600 mg is given. Well, here these are some operational guidelines for treatment initiation, and all TB patients are offered quality assured anti-TB drugs under the National TB Control Program. The treatment should be initiated by a trained medical officer, and in most of the situations, treatment may be initiated in the peripheral health institution, which caters to the patient's residential area. And in special circumstances, patient may have to be initiated on treatment in institution like medical college, hospital, etc. I still remember when after my MBBS, my first job was in the infectious diseases hospital, and the major portion of the infectious diseases hospital was dedicated to treatment of indoor in-house treatment of TB patients, and most of the patients over there were multiple drug-resistant TB patients or extensively drug-resistant TB patients. And then there were other wards as well, and you will be astonished to know because when I joined this institution, I also thought that I didn't have an idea that when it was established. In fact, it was established in 1926, and the medical superintendent of Mayo Hospital was also the medical superintendent of this infectious diseases hospital. The information required for treatment initiation of TB patients are drug sensitivity pattern and history of anti-TB treatment. Based on it, decision on treatment to be taken can be taken according to the all these things which you see in this slide. Then it's a brief overview of the pre-treatment evaluation. You can see that since the drugs used for the treatment of multiple drug-resistant TB are known to produce adverse effects, so a detailed history, including screening for mental illness, drug, alcohol abuse, etc., need to be taken. Weight has to be recorded, height has to be recorded, a complete blood count needs to be done. So, blood sugar, a few labs have to be done, which include complete blood count, blood sugar to screen for diabetes mellitus, liver function test, blood urea, and serum creatinine to assess the kidney function. Then, thyroid stimulating hormone levels to assess the thyroid function. Then urine examination, both routine and microscopic, and pregnancy test to rule out if the woman is not pregnant, if she is in the childbearing age group. Then chest X-ray, ECG if moxifloxacillin is to be used, and serum electrolytes if capreomycin is to be used. Well, as far as the follow-up schedule is concerned, you can see in this slide, of course, in this slide, it is again self-explanatory. No intensive phase extension, and if there is an intensive phase extension of 1 month, 2 months, 3 months, then how frequently the monthly follow-up examinations need to be done. Then in the extension of intensive phase could be for 1 to 3 months, and then the continuation phase, and then quarterly follow-up examinations in months are shown over here in this table. This is the management of patients who interrupt treatment, and it is not only this table. The next, the subsequent two tables in the following slides. This is table 4. Then we have a table 5. We have a table 6. So all of these show the management of patients who interrupt the treatment under revised National Tuberculosis Control Program, and daily self-administered non-DOTS regime is followed in exceptional cases when there is adverse reaction to drugs used in short course chemotherapy, or when the patient cannot comply with this regime, and the treatment is given like a non-DOTS regime. It is divided into different regimes. So you can see in this slide that treatment received before interruption, if it was less than 1 month, more than 1 month, then length of interruption was whether it was less than 2 months or 2 months or more, and similarly do a sputum smear examination, or was it no or yes, then result of sputum smear, was it negative or positive, then outcome, was there any default? If it was a positive sputum smear, then was a new registration done or not, and then treatment is started. This is another management of new smear positive cases who interrupt treatment, and again, all it's a kind of flow chart, I would say. And the patient must complete all 24 doses of the initial intensive phase, For example, if a patient has to continue his previous treatment and he took 1 month of treatment, that is 12 doses before interrupting, he will have to take one more month, that is 12 doses of the intensive phase treatment, and he will then start the continuation phase of treatment. But in certain cases, a patient who must start again will restart treatment from the beginning. And in certain cases, although this patient does not strictly fit the definition of default, default most closely describes the outcome of this patient, although at re registration they should be categorized as others. Then this is the management or retreatment of smear positive cases who interrupt treatment. These are of, this is the second category. So you can go through these tables. Well, again, this slide is self-explanatory, and patients who default, interrupt treatment for 2 or more months, and return back for treatment, such patients should be given an outcome of default and then re-registered for further treatment, which is based on the duration of default, as you can see in this figure as well as the next figure. Again, these are self-explanatory. The treatment duration prior to default was less than 3 months. 3 months to end of the intensive treatment phase or during the continuation phase. And according to the outcomes, everything is decided. It is an algorithm for management of multiple drug resistant and extensively drug resistant patients who default and return for treatment within 6 months of discontinuing a regimen for multiple drug resistant TB or extensively drug resistant TB. Again, this is the algorithm for management of multiple and extensively drug resistant patients who default and return for treatment after 6 months. So what you need to do is do culture. If the culture is negative, no treatment is required. Follow up patient periodically, and if the culture is positive, do first and second line treatment. And then if it is multiple drug resistant, re-register and start regimen for multiple drug resistant TB. And if it is extensively drug resistant, re-register and start regimen for extensively drug resistant TB. Here it is again a diagnostic algorithm for pediatric pulmonary tuberculosis. Cases of tuberculosis in children usually represent between 6 to 8% of all tuberculosis in the age group of under 15 years. And the source of infection to a child is usually an adult, often a family member with sputum smear positive tuberculosis. And the frequency of childhood tuberculosis in a given population depends on number one is the number of infectious cases, number two, closeness of contact with an infectious case, number three, the age of child when exposed to TB, and the age structure of the population. And diagnosis of pediatric TB is very important, and in children with presumptive pediatric TB, every attempt must be made to microbiologically prove diagnosis through examination of appropriate respiratory, non-respiratory specimens with quality assured diagnostic tests. And diagnosis of tuberculosis should not be made only on clinical features, and further investigations are always necessary to establish the diagnosis. So I'm not discussing this slide because it is there in front of you. I'm telling you a little more than what is back, or things which kind of add on to this slide. And in case of suspicion of pulmonary tuberculosis, sputum examination should be carried out among children who are able to give good quality specimens. And if Mycobacterium tuberculosis is detected by either of the methods, the patient is diagnosed as microbiologically confirmed pulmonary tuberculosis. So this is the best case scenario in which the treatment can be started. And in situations where Mycobacterium tuberculosis is not detected or specimen is not available, chest X-ray and tuberculin test, skin test by Monto's technique using the tuberculin units of PPD, RT23 should be done for interpretation and further course of action. You can refer to my previous lectures, or you can refer to the diagnostic algorithm for childhood pulmonary tuberculosis, uh, which you can see in this slide. Then, as far as pregnancy with multiple drug resistant tuberculosis is concerned, all MDR-TB suspects and patients of childbearing age should be tested for pregnancy as part of pre treatment evaluation and while on treatment. And if you remember, I showed you a slide of pre treatment evaluation in which it was mentioned that pregnancy tests should be done in all women of childbearing age before treatment is started. And if there is a history of amenorrhea of any duration, then again this pregnancy test should be performed. And they should be advised to use birth control measures because of the potential risk to both mother and the fetus. And oral contraceptives should be avoided. Use of barrier methods, condoms, diaphragms, the intrauterine contraceptive devices are recommended based on individual preference and eligibility. And of course, then the doctor should send the patient to either population welfare center to, or he or she should use the cafeteria choice from among these methods which I have mentioned, so that there is an informed consent from the patient. And the management of MDR TB patients with pregnancy is summarized in this flow chart, which you can see in this slide. Then this slide shows you causes of inadequate treatment. Again, this is self-explanatory. And drug-resistant TB has microbial, clinical, and programmatic causes. From a microbiological perspective, the resistance is caused by a genetic mutation that makes a drug ineffective against the mutant bacilli. Then further, an inadequate or poorly administered treatment regimen allows drug-resistant mutants to become the dominant strain in a patient infected with TB. You can see in the stable summarizes the common causes of inadequate treatment. However, it should be stressed that multiple drug-resistant TB is a man-made phenomena, and poor treatment, poor drugs, and poor adherence lead to the development of multiple drug-resistant TB. As far as all the member countries of WHO are concerned, in all countries, and especially those where the number of cases of tuberculosis is rising rapidly because of the association with HIV, the development of resistant strains of tuberculosis is a serious concern. So, moving further, this is just a chart to show you the category of adverse effects and what are the adverse events related to them. Like what could be the things which can take place related to autotoxicity. Different categories are given. Then what could be the psychiatric adverse events? What could be the neurological adverse events? Endocrine because of these medications. Dermatological, gastrointestinal, electrolyte abnormalities. Then nephrological, allergic, what are kind of arthralgia related adverse events can take place. And in case there are severe adverse events, then the drug has to be stopped, and the patient has to be re-evaluated, and then treatment continued accordingly. This is again, I've already discussed with you. You have seen in the previous slide, I got hold of this chart, was quite attractive. And just again, a little bit of repetition. The World Health Organization recommended doses of the first line anti tuberculous drugs and the second line anti tuberculous drugs. A little bit about tuberculosis and HIV. Worldwide, the number of people infected with both HIV and tuberculosis is rising, and the HIV virus damages the body's natural defenses, the immune system, and accelerates the speed at which tuberculosis progresses from a harmless infection to life threatening condition. Um, and the estimated 10% activation of dormant tuberculosis infection over the lifespan of an infected person is increased to 10% activation in 1 year if HIV infection is superimposed. So, tuberculosis is already the opportunistic infection that most frequently kills HIV positive people, and it has a severe epidemiological impact. HIV and tuberculosis interact in several ways. There is reactivation of latent infection, there could be primary infection, there could be recurring infection. In the community, there are more new cases of active tuberculosis because more people infected with tuberculosis develop active disease, and those newly infected become ill faster. And as far as this TB and HIV are concerned, diagnosis of tuberculosis in people with HIV is very important, and emphasis on integrated TB and HIV services, example HIV screening at through the National TB Control Program designated microscopy centers should be considered, and focus on early detection and early care is of prime importance. And in most people in the early stages of HIV infection, symptoms of tuberculosis are similar as in people without HIV infection. Then chest radiography is also important in these patients. Tuberculin skin test can be performed. HIV positive people with pulmonary tuberculosis may have a higher frequency of negative sputum smears, so confirming the diagnosis may require sputum culture. Then cases of extrapulmonary tuberculosis seem to be more common in people who are co-infected, and the treatment for HIV infected TB patients should be started immediately. Uh, then we have patients with tuberculosis and diabetes has been shown to be independent risk factor for tuberculosis in community-based study from different developing countries and multiple studies globally. And it has suggested that diabetes accounts for 20% of all tuberculosis and 10% of smear positive TB. And people with weak immune uh, system, as in diabetes, are at high risk of progressing from latent to active tuberculosis. And we should consider activities to improve diagnosis and management of diabetes among TB patients, activities to improve diagnosis and management of TB among diabetic patients. Then there should be joint monitoring and evaluation. TB patients diagnosed with diabetes should receive the same duration of TB treatment with daily regimen as non-diabetic patients. Did you know that tobacco makes tuberculosis worse? Uh, that's very important. Of course, smokers need to be worried about this, and more than 20% of the global TB incidents may be attributable to smoking. And tobacco smoke contains toxic chemicals which cause disturbance in the biochemical surface of the lung, and it also weakens the immunity of the patient to fight with tuberculosis, the tuberculous bacteria. And there has been evidence which emerges from several studies conducted to look at the association of TB and tobacco. And these studies show that almost 38% of TB deaths are associated with the use of tobacco, Then prevalence of TB is three times as high among ever smokers as compared to that of among never smokers, and the mortality from TB is three to four times as high among ever smokers as compared to that among never smokers. And smoking contributes to half the male deaths in 25 to 69 age group from TB in developing countries, especially in South Asia. And exposure to tobacco smoke has also been found to affect TB in ways like increase the risk of tuberculosis infection and the risk of developing TB, affect clinical manifestations, increase the risk of relapse from TB patients, increase tuberculosis mortality and drug resistance to anti-tuberculous drugs. Now I'm almost near the end, and the NTB strategy is of prime importance, measured by the numbers of people who die each year due to tuberculosis. It is the deadliest infectious disease, and it claims three lives every minute. Of the 9 million people who become ill with TB each year, more than 3 million are not diagnosed, treated, or officially registered by national TB programs. And collectively, these missed millions are a global public health failure. And this is especially the case considering that TB is airborne and that each undiagnosed and untreated person can infect as many as 15 individuals per year. So, moreover, TB continues to be the leading cause of death among people living with HIV. Likewise, drug resistant TB poses a grave challenge. So, as far as the evolution of NTB strategy is concerned, the NTB strategy developed in the context of the UN Sustainable Development Goals is a logical evolution and a paradigm shift from the past global TB strategies. The DOT strategy of 1994 helped revitalize national tuberculosis programs and equivalent entities by putting in place uh, pro- the essential basics to address the TB epidemic. As far as NTB strategy is concerned, it encompasses a package of interventions that can be fully adopted at country level, and it has 10 components organized under three pillars and four underlying principles. And if we move on to this slide, you can see the NTB strategy. What is the VN? What are the goals? The goal is to end the global tuberculosis epidemic. Then we have indicators and milestones as well as targets. As far as the indicators are concerned, the indicators include reduction in number of TB deaths compared with 2015 in percentage, then reduction in TB incidence rate compared with 2015 in percentage, then TB affected families facing the catastrophic costs due to TB in percentage, then the principles of this NTB strategy include government stewardship and accountability with monitoring and evaluation, strong coalition with civil society organizations and communities, protection and promotion of human rights, ethics and equity. And the last principle is adaptation of the strategy and targets at country level with global collaboration. And then you can see the pillars and components which I have already mentioned. You can get back to this slide and see the things. Then the global plan targets are designed as 90 targets. 90% of all people with TB, we have to reach out at least all of them. And as a part of this approach, reach at least 90% of the key populations, achieve at least 90% treatment success. So, talking about the reaching out, achieve at least 90% treatment success for all people diagnosed, or reaching out to populations is concerned. The key population groups are highlighted in this slide, And the global plan defines key populations as people who are vulnerable, underserved, or at risk of TB infection and illness. And for purpose of the global plan, three key population groups are further expanded as shown in this slide. Along with examples of population within these groups, it is important to note that people who are likely to fall into one of these categories are also likely to be part of one or both of the other groups. And despite effective case finding and therapeutic tools and declines in mortality and morbidity rates in some countries, tuberculosis appears to continue as an important communicable disease problem worldwide for several decades to come. And the chronic nature of the disease, the ability of the tubercle bacilli to remain alive in the human body for years and years, the concentration of the disease in the older age groups, the increased expectation of life, the high prevalence of infection rates in some countries and relatively high reactivation rate, the emergence of drug resistant strains, association of tuberculosis and HIV infection, and above all, the perpetuation of the non specific determinants of the disease in the third world countries impede a rapid conquest of disease. With this, I end today's session. Again, a reminder that how you can report patients, and this poster shows you what the government is doing. This is a slide showing the Punjab province in Pakistan. With this, I end today's session with gratitude, saying Alhamdulillah. And the takeaway message is that every breath is a gift from Allah Almighty. And you, as physicians, as healthcare providers, as healthcare professionals, and allied professionals, have to play your role in prevention of tuberculosis. As I always say, prevention is better than cure. With this, I end today's session. Thank you so much. Allah Hafiz and take care.